Welcome to The Explainer, where we take really complex clinical puzzles and just break them down into clear, actionable knowledge you can actually use.
Okay, so picture this. You get a set of labs back, and bam, the first thing that jumps out at you is a pH of 7.2. That is a huge red flag. And that number? That's not just data. That's your first clue. Today, we're putting on our detective hats because we are going to solve the case of metabolic acidosis step by step.
So here's our game plan, our investigative roadmap, if you will. We're going to start with the basics. Then we'll follow a really critical clue, identify all the potential suspects, and then finally, we'll close the case with a solid management plan. All right, let's get into it.
First things first, every good detective needs to know exactly what they're up against. So let's define our terms. What is metabolic acidosis really?
You know, it's super important to get our terminology straight right from the start. Acidemia is the state of the blood. It's that low pH number we saw in the lab report. But acidosis, that's the underlying process that's making the pH drop. So you can think of acidemia as the symptom and acidosis as the disease causing it. Make sense, right?
Now check this out. This table maps out the 4 main ways our body's pH can get thrown off. For our investigation, we're laser focused on that top left corner. We see a low pH, that's acidemia, and we pair it with a low bicarbonate level. And that combo points directly to our prime suspect, metabolic acidosis.
And the body is smart. It doesn't just sit there. It launches an immediate counterattack. The second that bicarbonate drops and the blood gets too acidic, the lungs just jump into action. They start working overtime, making the patient breathe faster and deeper to blow off as much carbon dioxide as possible. Why? Because CO2 acts like an acid in the blood. It's a really fast way to try and restore balance, but look, it's a temporary fix, not a cure.
So the lungs are helping, but are they helping enough? Or maybe too much? Well, that's where Winter's formula comes in. This handy little equation is our fact checker. It tells us exactly what the PaCO2 should be based on the bicarbonate level. If the patient's actual number matches the formula's prediction, awesome, the compensation is appropriate. But if it doesn't, that's a massive clue that something else is going on. We might have a second mixed disorder on our hands.
All right, quick recap. We've got our primary problem, low pH plus low bicarb. We know the body's first line of defense is the lungs. And now we have a secret weapon, Winter's formula, to make sure that defense is playing by the rules. Now we're ready to find the real cause.
Okay, let's get to what I think is the biggest lead in this entire investigation. This is the one clue that's going to split our case wide open, sending us down one of two very, very different paths.
And that clue is the anion gap. Now, this isn't something we can just, find in the blood. It's a calculated value. Basically, our blood has to be electrically neutral. So the anion gap represents all the negative ions that we just don't bother measuring on a routine lab panel. It's our way of asking, has some kind of mystery acid been secretly added to the system?
And this right here, this is the formula that's going to drive our whole investigation forward. It's so simple. We just take the main positive ion, sodium, and subtract the 2 main negative ions we measure, chloride and bicarbonate. The number we get? That's our anion gap. Deceptively simple, but incredibly powerful.
And this is it. This is the fork in the road I was talking about. If the anion gap is high, it tells us an unmeasured acid has been added to the blood. The bicarb is getting used up buffering this new acid, and the acid's leftover anion creates that gap. But if the anion gap is normal, it means something totally different. Bicarb is being lost directly from the body, and the kidneys are holding on to chloride to keep things balanced. So the question is, are we dealing with an added acid or a bicarb leak?
Now here's a crucial pro tip. This is something every detective on this case has to remember. Albumin is the main unmeasured anion. So if your patient has low albumin, your calculated anion gap is going to be falsely low. You have to correct for it. Trust me, this tiny step can be the difference between completely missing a high anion gap acidosis and cracking the case wide open.
All right, so let's say our investigation has led us down the high anion gap path. We've chosen our direction. Now it's time to line up the usual suspects, the culprits responsible for adding these mystery acids into the blood.
So these suspects, they tend to fall into 3 main categories. First, you've got the body itself just going haywire and producing way too much acid. Think lactate in a patient with sepsis or ketones in DKA. Second, the patient has ingested some kind of poison like methanol or aspirin. And third, the kidneys, which are supposed to be taking out the trash, are just failing to do their job.
And this right here is where the lab values on the screen meet a real, live patient. We don't solve these cases just with numbers. For something like DKA, the history and the physical exam give you overwhelming evidence. You find out the patient has diabetes, they're breathing really deep and fast, and you might even smell that classic fruity odor on their breath. The clinical picture perfectly confirms what the high anion gap was telling you.
Okay, let's hit rewind for a second. What if we took that other path at the fork in the road? What if the anion gap was normal? Well, this changes everything. We're no longer hunting for an added acid, now we're on the trail of a bicarbonate leak.
And on this path, our list of suspects looks completely different. The number one most common culprit is losing a ton of bicarbonate from the GI tract. Think really severe diarrhea. That's a classic. The other major source of these leaks is the kidneys themselves, which we see in a group of conditions called renal tubular acidosis. And believe it or not, sometimes we're the cause by giving patients huge volumes of normal saline.
You know, sometimes the initial clues just aren't enough. For those really tough cases, the ones where maybe there's a mixed picture or the cause isn't obvious, we have to bring out the advanced forensic tools.
And this table here is a fantastic summary of our advanced toolkit. The delta-delta ratio, that's perfect for unmasking a second, hidden metabolic problem lurking in the shadows. The osmolog gap, that's our go-to test for suspected toxic alcohol ingestions. And the urine anion gap helps us figure out if a normal anion gap acidosis is coming from the gut or the kidneys. Each test answers a very specific and very crucial question.
Okay, we've followed the clues, we've interviewed the witnesses, our labs, and our physical exam, and we've identified the culprit. The investigation is complete. Now it's time to write the final report and lay out the plan to restore order.
So the most important thing about management is this. Step 1, 2, and 3 is to treat the underlying cause. If it's sepsis, you give antibiotics and fluids. If it's DKA, you give insulin. Giving sodium bicarbonate is not the cure. It's a temporary bridge, a band-aid that we only use in the most severe, life-threatening cases because honestly, it comes with its own set of problems. And for some poisons or really bad kidney failure, dialysis is our ultimate intervention.
So here it is, your complete investigative checklist. Follow these steps every time. You start with the basics. You calculate the anion gap to narrow your search. You consider the list of suspects for whichever path you're on. You use the advanced tools when you need them, and you always focus on treating the root cause. This framework turns what looks like a confusing set of labs into a solvable case every single time.
You see, this whole approach isn't just about passing an exam. It's a powerful framework for thinking like a real clinical detective. So the next time you see that critical lab value, that low pH, you'll know exactly where to begin your investigation. So I'll leave you with this. What subtle clue will you look for first?